right, I think we're going to go ahead and get started here. Thank you all for coming. If you haven't grabbed a bite to eat, feel free to grab one in the back. But thank you all for coming for today's thyroid eye disease briefing. We're going to talk a little bit about the disease, the condition, how it impacts people, the research that's happening in the space, the current care continuum and the opportunities for treatment, and where research continues to go to try to improve outcomes for patients. We'll also have a little bit of a patient perspective to hear the real-world impacts of what thyroid eye disease, how it impacts patients, and what it means to have new treatments and therapies available. So we're going to cover all of that, and then we'll have an opportunity to also hear from some of our partners at the Vision Health Advocacy Coalition to hear about some of the things that you all may be able to do in the access and coverage and care space and on vision as well. A little bit about who we are. So we are the Alliance for Eye and Vision Research, and we're a 501c3 nonprofit organization, and we serve to educate about the value and impact of vision research, specifically federally funded vision research, the impact that that has on developing new treatments, hopefully new opportunities for patient care that can continue to improve patient care. And our focus really focuses on the National Eye Institute, funding for that, support for the NIH as a whole, and trying to drive research that develops those new pipelines, those new treatments, new discoveries, so that we can have new treatments in the future. I want to thank our sponsors. We're here today because our sponsors help support these briefings and support these events. So we want to thank Amgen for their sponsorship of today's briefing, as well as ARVO, Research to Prevent Blindness, and the Vision Health Advocacy Coalition, all of who helped make today's briefing possible to be able to share some of the information with you all. So what is thyroid eye disease? It is an autoimmune disease that is a debilitating and progressive disease that can cause significant vision impairment and vision loss. It basically causes the muscle and fat tissue around the ocular surface to become inflamed and swollen, and can impact the ways in which the eye protrudes from the skull, and the ways in which it can also impact vision. Some of the ways that it impacts the thyroid is it's basically a overproduction of the thyroid hormone, and it causes the tissue around the eye to swell. The estimated impact is over 3 million Americans, with about 15 to 20,000 Americans that are impacted by thyroid eye disease every year. So there are, initially, thyroid eye disease was thought to be a very rare disease, and we are finding out now that treatments are becoming available that thyroid eye disease is much more prevalent in the population than we originally anticipated. And so it's really important that we address this. Some of the symptoms from thyroid eye disease include light sensitivity, grittiness and dryness in your eyes, excessive tearing, swelling of the eyelids, eye bulging, which you'll see some examples of, double vision, which can severely impact people's ability to function, work, and live independently, misalignment of the eyes, and progressive vision loss can also occur. So who's at risk for TEDS? Up to 50% of people with Graves' disease, which is the most common form of hyperthyroidism, develop thyroid eye disease. Women are 5 to 10 times more likely to develop thyroid eye disease. And it typically manifests in older populations, so you start to see it in adults after their 40s, although it can be diagnosed and be seen in patients that are younger than that. And then smoking is one of the contributing factors, we believe, to thyroid eye disease as well. It's estimated that people who are smokers are at an 8 times higher risk for developing thyroid eye disease. Some of the signs and symptoms, you can see here an example of a patient with thyroid eye disease, and you'll hear from a patient about what their experience has been. But again, some of the challenges that you have are not only from your own personal experience and challenges with red and irritated eyes, swollen eyes, and things like that, but you can also see that it has a significant impact on your appearance, and that can have a real impact not only on your comfort level travel as a patient with thyroid eye disease, going out and being public, and being in public, but also can lead to some of these other challenges that you see with blurred vision, double vision, and things like that. The impact of thyroid eye disease, it impacts how we feel. Across all vision conditions, mental health is a real issue for folks that experience vision loss and vision impairment, and thyroid eye disease is no different than that. It really does have a direct impact on patients' perceptions of themselves, their perception in the community, and can have some serious mental health challenges for patients that experience thyroid eye disease. And that was even more so the case, I believe, before we started to see treatments in this space. A lot of challenges with respect to driving and independent living. Those are things that can result from the double vision. And like I said, some of those issues with mental health and depression, anxiety, and social isolation can occur with folks who experience thyroid eye disease. So broadly, what are some of the treatment options available? You'll hear a little bit more about this from Dr. Wohler, but basically there's observation. You can kind of look and see what ways that you can treat it through steroid treatments and injections. There are some different sort of ways that you can, that have historically been used to treat thyroid eye disease. You may have seen commercials, and you'll kind of get reference to this in a minute, but there is a new marketable therapy for thyroid eye disease that is available to patients now for the first time. So we're really excited about that. And there's also new treatments that are being developed right now in the pipeline thanks to new discoveries and innovations across the vision research space that are leading to new and innovative treatments that can also support this community. There has also been a method for treatment which includes surgeries, and surgeries are still an option for a lot of patients, but we are trying to look at ways that we can treat and cure thyroid eye disease through advancements in research and advancements in the clinical care, and hopefully bringing new marketable therapies and emerging marketable therapies to patients so that we can get access for patients. And with that, that's sort of a high-level overview. I'll have Dr. Colin Wohler from University of Rochester come up and share a little bit more about some of the research that's happening in this space and some of the work that's being done to treat and address thyroid eye disease. So, Dr. Wohler?
All right, thanks, Steve.
Yep.
All right, great. All right, well, it's great to see you here, and thanks for coming. And I'm excited to be able to give you a little bit of overview about the current field of research in thyroid eye disease. So let me see, does this have a laser pointer option? That's all right. No, it's okay. We don't need it. So we'll jump right into it. All right. So let me take you back a couple hundred years, maybe. All right. So before the recent prominence of thyroid eye disease, it was pretty obscure. There wasn't really a name for it, and we had multiple different people observing patients and trying to describe this. And so several of them have sort of been documented. One of the first ones was this guy, von Bastow, who really described this exophthalmos due to hypertrophy of the cell tissue in the eye socket, right? So that is the orbit of the eye, where the eyeball is held. He saw patients that had this expansion of this tissue, so their eyes were actually bulging out of their head, right? Robert Graves, who obviously the namesake of Graves' disease, published on it first sort of these same types of descriptions of some patients who were seeing this tissue expansion in the eye, but they really didn't have any idea. They knew it was something to do. Their heart rates were often elevated, but really they could just describe this tissue, and there wasn't really anything they could do, right? So there was nothing. And then of course they found even almost 200 years ago now. Caleb Perry actually described some findings, and they've also called it Perry's disease. And he showed in his unpublished work describing some of these patients who had disease. And of course, let's fast forward another 100 years or so into the 60s, 70s, and 80s. As we find more things about this disease, people decided to, started to try to describe it more, make names that were more descriptive. So they knew it was linked to the thyroid. So we originally called the dysthyroid orbitopathy. Then it moved into thyroid orbitopathy. And further linking it to Graves' disease was Graves' orbitopathy or ophthalmopathy. And then one of the most recent name changes was thyroid-associated orbitopathy, right? So you can see people really didn't know what to call it. They knew that these patients were affected, they had this disease, but really the name is just starting to really be coming into a consensus in the field where we have the more preferred name of thyroid eye disease. So what changed? What changed? Why all of a sudden, are we able to know, more people have heard about thyroid eye disease? And one of the things I think, let's see if I can play this here, was really the great success of
With
this.
thyroid eye disease, I hid from the camera, and I wanted to hide from the world. For years, I thought my TED was beyond help. But then, I asked my doctor about Tepezza.
Tepezza is the only medicine that treats TED at the source, not just the symptoms. In a clinical study, more than 8 out of 10 patients taking Tepezza had less eye bulging. Tepezza is an infusion. Patients taking Tepezza may have infusion reactions. Tell your doctor right away if you experience high blood pressure, fast heartbeat, shortness of breath, or muscle pain. Before getting Tepezza, tell your doctor if you have diabetes, IBD, or are pregnant or planning to become pregnant. Tepezza may raise blood sugar even if you don't have diabetes, and may worsen IBD such as Crohn's disease or ulcerative colitis.
Now, I'm ready to be seen again.
Visit mytepezza.com to find a TED eye specialist and to see Bridget's before and after photos.
Do this for flat
Okay,
belly at
we'll
60s.
We'll close this now. Sorry about that. Okay. All right. So we got the idea, right, that just in the last 5 years, really, there's been a lot more known about thyroid eye disease, and this really comes as the fact that there's a targeted therapy. And I want to talk to you a little bit more about that as we move forward. All right. So let me give you a little bit of background. I know Dan also gave some of this background, but I'll just kind of reiterate it. All right. So we know that this disease is connected to autoimmune thyroid disorders. But it's not just Graves' disease. So Graves' disease is hyperthyroidism, but you can have this disease with other thyroid disorders, including Hashimoto's thyroiditis, which is a hypothyroid disorder. And some people are even normal thyroid hormone levels, right? So you can see this disease in many different types of patients. But one of the underlying things is there is some autoimmune thyroid component to it. And around 20 per 100,000 people are diagnosed with TED every year, and that's sort of, I think, a low estimate. I think as we understand more about TED and get better diagnostics, this may actually increase. And it does affect around half of patients with Graves' disease, which is, of course, the most common targeted population for thyroid eye disease. But you can get it with any type of TSHR autoantibody, so it's an autoimmune disease. And some of the symptoms, as you can see from this diagram, right? Proptosis, which is bulging eyes. Okay, diplopia is double vision, so you can imagine seeing two things. Maybe we'll see more of that in the next talk by Nathaniel. You can also see dryness and grittiness, so that's kind of that sand feeling. And you can have light sensitivity, so you saw in the commercial, the patient was wearing sunglasses because the light was really painful to actually be exposed to. And really in severe cases, you can get optic neuropathy, which is compression of the optic nerve, and vision loss. Right? Okay. And I think this is really one of the things now we're realizing is that TED is really underdiagnosed in the population. I think we just don't have great ways to diagnose the disease, right? We need better ways to look into that, right? And in fact, I think, because we have delayed diagnosis, we can actually see that sometimes some of these patients aren't getting the treatment they need, and we have worse outcomes later on. All right, some of the risk factors that we've talked about, again, TSHR autoantibodies, whether they're stimulatory, like in Graves' disease, blocking, like in some Hashimoto's thyroiditis patients, or maybe just interfering. These interfering antibodies really seem to be one of the main underlying causes of the disease. Smoking, cigarette smoking here, we're talking about, it increases your risk 7-fold at least, potentially more. So clearly, smoking is a huge preventable risk factor for this disease. We also see some deficiencies in vitamins, including vitamin D deficiency has now been linked to TED manifestation, as well as in some places we see selenium deficiency also contributing to this. It does happen to affect people who are older more severely than others. Microvascular disease, this is sort of any disease where you have like thinning of your vessels, can also contribute to this. It is more common in females, but it turns out males can often display more severe disease. So there are clearly some differences in terms of the sex of the patient and how they respond to the disease. Here you can see a patient where they're having significant proptosis, and here you can see it affected this male patient differentially in each eye, right? So he's no longer able to control the muscle in his eye because the muscle is expanded severely. So that's what's happening here. Okay. So when we talk about disease progression, oftentimes we think of TED in sort of an active phase, which is really when you see those, active inflammation and immune cells infiltrating into the eye and the orbit. That's where you see the eye redness and see this sensitivity to light and pain in that way. And you can see this often does sort of progress, and you get into a more inactive disease phase later on, which is sort of when this tissue starts to remodel. So you can imagine, you're affecting the entire orbit and the eye through this inflammatory disease process. But after that inflammatory disease process starts to reduce, the tissue actually remodels, and you can get a lot of different secondary effects in this part of the disease. And unfortunately, this happens sort of heterogeneously, right? So patients can have various stages or severity of tissue remodeling when it comes to this inactive phase of the disease. Often some patients get severe disease, some people get more of a mild disease, and sometimes it even regresses on its own, right? But it's really unclear why that happens. So let's go into some more of the pathology of the disease, right? So here you can see we've got some CT scans from some patients. Let me just sort of orient you on what we're looking at here. We're looking at a scan of the skull, obviously, and you can see the eyeballs, and you have a control patient, and then we have some TED patients in the middle and the right side of the image. And what we're looking at, of course, is the orbital space behind the eye, right? And so you can see that we have that space to support the eyeball, but what happens in thyroid eye disease is you get expansion or increased volume of that orbital tissue. And sometimes that tissue can expand in terms of fat, and that's what the middle image is showing you. That CT, it almost looks like there's empty space. It's actually not empty space. And that's sort of what this, sorry for those of you who are eating who might be grossed out by this picture. This is actually orbital fat, which would show up sort of as clear space in the CT scan because it's less dense. But you can see there's lots of different fat that's actually increasing in the volume in that patient there. But you can also manifest the disease with muscle expansion. In muscle expansion, the muscle tissue is more dense, so it picks up on one of these CT scans. And so, but what you can really see is that volume increases in the orbit, and the eyeballs are actually proptosing out from the head. And that's what we want to see here. Or that's what we're showing in these images. In addition to either the fat or muscle expansion, some patients can get expansion of both types of tissue. And we also see increases in other material, extracellular matrix material like hyaluronic acid. Hyaluronic acid you may have seen it, it's actually in certain lotions as a hydrating cream, right? Because hyaluronic acid is really great at absorbing water. And it actually helps move your joints around. You keep some lubrication in your joints with hyaluronic acid. But the problem is when you get too much hyaluronic acid in your orbit, water starts to deposit there and you get tissue swelling. So you can see actually that's actually a negative thing to have this excessive accumulation of hyaluronic acid. Collagen is another extracellular matrix protein that can be increased as well in these patients. Okay. So traditionally, historically, what were the therapies that people were using to treat TED? Corticosteroids were sort of the mainstay, sort of just suppressing this broad immunosuppressive agent was given. Oftentimes you get systemic steroids. They can reduce the inflammation, but they also carry significant side effects. I think we'll hear more about some of that later as well. Some patients were receiving targeted radiation. Like sometimes you can give radiation to cancer patients to kill out those cells. We were sometimes giving TED patients orbital targeted radiation plus steroids, but the efficacy of that was not really completely proven, and it remained controversial. Right? So once those were tried, oftentimes what we had once you got into this less of an active disease, because going and doing surgery on a patient with active disease is not recommended. So once this disease has sort of gone through its active phase and sort of controlled, you could go into decompression surgery. And so this was really, you can see here the effects of a before and after picture of a patient who had successful decompression surgery. And there are other types of surgery as well that some of these patients get. They have muscle surgeries or lid surgeries as well. But here we're just giving you the decompression surgery of the orbit. And these treatments are really aimed at controlling the disease rather than targeting or curing it. We also have gone through many other different treatment regimens, mostly immune suppressants, right? And these often only work some of the time, right? So mycophenolate and azathioprine, they block purine synthesis, which is a precursor to DNA, so it prevents immune cell proliferation, and it can also reduce antibody production. So that was beneficial here to target some of the disease. Cyclosporin is another one of these broad immune suppressants which blocks production of a protein called IL-2, which reduces your T cell activation. That was also used in some of these patients. And more recently, we're getting into the age of biologics, right? Biologics are antibody-based therapies. Some of the ones that have been tried are rituximab, which blocks B lymphocytes. B lymphocytes are the antibody-producing cells, so the ones that produce the autoantibodies in this disease could be potentially blocked with rituximab. And tocilizumab is another biologic that blocks IL-6 receptor. IL-6 is another one of these inflammatory cytokines that causes inflammation in the orbit, and so reducing activity of this cytokine often seems to lower the inflammatory phase of the disease. Okay, but these broad immune suppressants don't always work. They also have secondary side effects. And so that's when we started to talk about, let's go into the research field, let's go into mechanism of some of these things. And so we can understand, if we can understand how the disease actually, the pathophysiology goes forward, maybe we can start to target it a little bit better, right? Okay, so let me bring in one of these first proteins I want to talk to you about, thyroid stimulatory hormone receptor. All right, abbreviated TSHR. It's expressed on the surface of some cells. And traditionally, what we think of it as it's responsible for controlling the production of thyroid hormones T4 and T3, right? So normally it binds to its ligand, thyroid stimulatory hormone. It binds to this receptor, which leads to production of thyroid hormones in your thyroid, all right? So in addition to being expressed in your thyroid, it turns out some other cells express this receptor as well. Some of these include cells called fibroblasts, which I'll talk to you a little bit about, and fat cells, adipocytes. And both of those types of cells are also in the orbit, okay? So for some reason, we also have this receptor that's normally controlling thyroid hormone levels, also expressed in orbital tissue. Okay. Now, most TSHR autoantibodies in TED are stimulatory, and that's where we have hyperthyroidism, as in the case of Graves' disease. But we know that that's not always the case. And we can see that some antibodies can be blocking antibodies to this receptor, or they can just interfere with the receptor as well. But we do know that we have these antibodies in TED. Okay, so that's the first receptor I want to talk to you about, and now we're going to bring in the second receptor that sort of sits. What's thought of as sort of sitting right next to the TSHR on the surface of a cell, and that's the insulin-like growth factor 1 receptor. And the insulin-like growth factor 1 receptor, IGF-1R, it can stimulate cell proliferation. It can produce hyaluronic acid, right? That same component that I said was increased in the orbits of TED patients. It can also activate fibroblasts. And the thing about IGF-1 receptor is it's not just expressed in the thyroid or in orbital fibroblasts and orbital adipocytes. It's also expressed in almost every cell in the body. So that's an interesting, but we know in the case of, in the orbit, that these two receptors are sort of huddled together, and they can sort of feed off each other and stimulate this activity, right? So it looks like in thyroid eye disease, there is crosstalk between these two proteins on the surface of cells, and they stimulate not thyroid hormone production in this case, but cell proliferation, production of hyaluronic acid. They can also increase muscle tissue expansion, promote adipogenesis, those fat cells. So we can see that this complex is really driving a lot of the pathophysiology of this disease. Okay? So, while I got you here, I just wanted to talk to you a little bit about more of these cells that we're talking about, fibroblasts, right? So fibroblasts are often thought of, if you took, biology, you learn about them as being sort of the structural cell that kind of hold the shape of different tissues. But it turns out they're much more important than just structural cells. They actually are sentinel responder cells. So they play a part in the immune response, inflammation, tissue remodeling, you name it. They're really sort of these workhorses in the body. And it turns out you can have them obviously from these various tissues resident to the orbit. You also have fibroblasts that can be in circulation in the blood, called fibrocytes. You can also get fibroblasts from stem cells. And it turns out fibroblasts is sort of a generic name, and these cells can be very heterogeneous. So the cells can kind of have different responses. They can respond in different ways. And it turns out in the orbit, these fibroblasts are IGF-1 receptor positive, TSH receptor positive, just like that diagram was showing you. And these cells, depending on how they behave, can form this extracellular matrix, hyaluronic acid collagen. They can also form the myofibroblasts or muscle cells. They can form lipid accumulating adipocytes, so they can expand in the fat tissue expansion as well. And they also make these mediators called cytokines and chemokines, which are part of the inflammatory response as well. So you can imagine that these fibroblasts are sort of controlling the inflammation and tissue remodeling in thyroid eye disease. And like I said, the pathway that seems to be driving them is through this TSHR IGF-1 receptor complex. And that's the beauty of teprotumumab, Tepezza. So Tepezza was actually originally identified. It turns out that in many human cancers, the IGF-1 receptor is also overexpressed. So years ago, companies started to target the IGF-1 receptor to see if it would be actually to stop cancer cells, right? So they were able to do some of these safety studies in cancer patients to show it. Unfortunately, it didn't stop most cancers, but it was safe. And so, sort of fortuitously, researchers in the TED field realized, hey, we know we have IGF-1 receptor activation in this tissue. There are already IGF-1 receptor blocking antibodies out there. What if we test it out here? And it was amazing. That was really some of the greatest success that we've seen in the field of thyroid eye disease. Taking this medicine that was developed for cancer, putting it into thyroid eye disease. And you can see the results from a clinical trial that were published in the New England Journal of Medicine. In 2020, we had dramatic success in treating these patients. You can see a dramatic reduction in proptosis. and inflammation in some of these patients. And so, of course, the way Tepezza works is it was able to take out part of this receptor complex. It takes out that IGF-1 receptor, so you no longer have that pathway activated in your fibroblasts. Okay. But unfortunately, as I did mention, the IGF-1 receptor is expressed on almost every cell in the body, and it turns out that a lot of these patients did experience some side effects. Some of the most prominent side effects, significant side effects, including hyperglycemia, were hearing impairment, muscle spasms, and you can see this variety of different adverse effects here. So this middle column are the patients that were receiving Tepezza in the trial, and then these are the placebo groups. You can see that we have certainly more impacted through hearing impairment and hyperglycemia and muscle spasms in that group of patients. Okay, so that being said, we know a little bit about the research. Teprotumumab is an exciting advance, and it reveals that TED can be targeted, right? But we have some patients do not completely resolve with Tepezza treatment, right? And some patients even respond variably. Some have not responded at all. The other problem with Tepezza is availability and cost. This is a significant cost to patients, and it's not available everywhere. And there are some of these adverse side effects, like I was mentioning, hearing loss and hyperglycemia and muscle spasms. And this is an infusion process, so you actually have to receive refusions for Tepezza, and sometimes patients are relapsing after stopping of the infusions. Okay, so there are some caveats to this great success story, right? So yes, teprotumumab has really changed and radically improved management of TED. And if we look on the map, there are many different additional IGF-1 receptor blockers that are starting to be looked at and starting to be thought of. And we have these me too, or maybe this will work aspect of if IGF-1 receptor is a great target, maybe others to target that same pathway will also work. But there are also novel approaches coming down the pipeline as well. However, we still don't know yet, right? This is still just up and coming, right? And so we have some challenges to meet. This, again, is an infusion. We'd like to have non-infusion delivery of these. We'd like to also improve the cost-benefit. And we'd also, it would be really important to be able to prevent this disease with earlier diagnosis and potentially prophylaxis, right? If there's something you could take that was relatively safe and effective that could actually prevent you from getting the disease in the first place, this would be ideal, right? So new therapies and targets are still needed. IGF-1 is a great step, but I think there's more to be done, okay? I'm just going to briefly go over some of this, sort of exciting new data. So the field of science is obviously rapidly exploding. There are lots of new technologies where we can actually sequence all of the different RNAs and all the different cells from these patients. So in one recent study, we basically took this orbital decompression tissue that was being removed from a patient, and they sequenced the RNAs from every single cell. And you could make these little dot plots, right? These dots represent individual cells and their individual expression profile of various RNAs. And what was really interesting to us to see is that, of course, the fibroblasts make up sort of this biggest component of cells. So that's that big population in the middle. There are also other inflammatory cells like T cells, myeloid cells, monocytes, macrophages, also present in there. But what's really exciting was this really large abundance of fibroblasts. And when we look closely at that layer of fibroblasts, we can cluster them into these myofibroblasts, think about the muscle expansion, lipofibroblasts at the fat expansion, and then some control fibroblasts as well. So we could see that these fibroblasts are really sort of clustering in different ways, and they could potentially contribute to the disease with this gene signature. And some of the work that we've been trying to do is to sort of go after these different cells and these different fibroblasts and see how we can limit their ability to make that excessive muscle and excessive fat tissue that we see. And we're going through some of these. This is just one receptor, which I'm not going to spend a lot of time on, just to know that we've been thinking about it. It turns out we think this receptor is an important therapeutic target in thyroid eye disease. We've been able to successfully limit the production of these muscle-forming cells by giving cells AHR ligands. So these are these molecules that can bind to this receptor and limit their formation of muscle cells. We've also, and actually interesting, one of these compounds that can activate this receptor is esomeprazole. So it's a proton pump inhibitor, but it turns out it has this secondary effect that could also increase the activation of this receptor, right? And I'm just going to jump through this. We've also started to look at the lipofibroblast pathway, and it turns out there's this other compound called metformin, which is actually a drug that many type 2 diabetics are taking. And it turns out that metformin can limit lipid accumulation in this way. So we're really trying to use some of these existing molecules and seeing if they can actually prevent accumulation of some of these lipofibroblasts and scar-forming fibroblasts in these cells. So that's really, I think, one of the ways we can take the recent data from all of these studies, understand the differentially regulated pathways, and try to identify new therapeutics in this pathway. All right. It is a complex autoimmune condition. We've made a lot of progress, but there's much more to do, right? And there's a lot of questions. Can we, identify new biomarkers? Can we intervene earlier? And can we still further understand this disease? And I think that's really where, we have to take the next steps in research. And so, these are just a list of things that I think where the field is going, what we think we still need to do, personalized treatments. We didn't really touch on it too much, but the microbiome may be playing a role. Again, these next generation technologies, and really harnessing artificial intelligence to develop and model this disease. So it's really been, sort of a whirlwind to just take you through some of the research and I think some of the opportunities. I'd like to thank my lab, and my lab is funded by the NIH and National Eye Institute, and and also from the Research to Prevent Blindness. So very fortunate to have that funding. And from there, I'm going to hand it over. I think back to Dan. Okay, great. All right.
Awesome.
Thanks.
Thank you very much. We're going to hear from a patient perspective now, but I want to emphasize that a lot of this research that's being done has helped develop this new treatment for thyroid eye disease that we now have, and the treatments that are forthcoming, and the work that Dr. Wohler mentioned that we need to continue to do in the research space. That is mostly funded by the National Eye Institute, which is then picked up by industry to be able to bring these new therapies and treatments to market. So really support appreciate the support from the National Institutes of Health, and specifically the National Eye Institute. Now I'm going to introduce Dr. Nathaniel Jelinek to be able to talk a little bit about his experience with thyroid eye disease.
Great, thank you.
Nathaniel?
All right. Sorry. Thanks. So, yeah, this is me the way I want it to look. I'll show you some different pictures a little bit later. So my name is Nathaniel Jelinek. This is my story with thyroid eye disease, or we call it TED colloquially, and this is an appropriate time to talk about this because this is TED Awareness Week, and so a good time to have this. So, about me, I'm a physician, and so I'm not a researcher or an ophthalmologist, but I do have a slightly different background, so approach this slightly differently than with a more scientific perspective. And I work as a skin cancer surgeon. I've been practicing for almost 20 years in Rhode Island. And I have a specialty in nail disease, and I'm very involved in education and mentoring. And being a physician is a big part of my life, and this interfered with it dramatically. I also am just an individual with a family that has people who have sort of struggled to watch me work through this disease and supported me during this. And I'll be speaking mostly from that perspective. So in the summer of 2022, my face changed. So I developed this prominent swelling, not just in my eyes, but my whole face. My eyes hurt, they watered constantly, they were gritty, they bulged. I had no idea what was going on. At night, I would wake up and I'd have tears streaming down my cheek because the eyes couldn't close completely, and in an effort to protect my eyes, they would just tear over tear. I didn't know what was happening. I started developing double vision. And over the span of a few months, despite having no thyroid disease, I was diagnosed correctly with thyroid eye disease, which is actually the short end of the spectrum. So I think I was fairly lucky. And it is a distinct autoimmune disease. And I was treated, as Colin had said, with the immunosuppressive. So I was on high-dose steroids for months. And as a dermatologist, we treat people with steroids all the time. And I was on higher doses than anyone I'd ever treated before. And it'll make you crazy. And that's first-line treatment now, still. And so I had all of those side effects. And then I got on Tepezza, which is the only FDA-approved treatment for the disease. So that is an important fact. And I continued to work this whole time because that's like what I do. You know, I love it. It is a real calling for me. I'm passionate about being a physician. So I was manic, irritable, you know, sleep deprived, but I kept working, and my eyes improved dramatically. I mean, I had a near complete recovery. I mean, I'm very grateful for the R&D that ends up with these drugs that, you know, put me back on the map. Unfortunately, 9 months after I completed therapy, my disease returned, and it returned worse. And so this time, instead of just the facial swelling, I had just progressive double vision. And it is so disorienting. It's so disorienting that you just decide to wear an eye patch much of the day, because just seeing two of everything, it breaks your brain. And this happens when there's so much swelling, as Colin explained, behind the globe, behind your eyes, that the globes can't move together. So if they're tracking and one of them goes here and the other one can't, then you all of a sudden see two of everything. And it's just the autoimmune disease affecting the fibroblasts, everything we just saw behind the eye. And so one day I was operating, and this became what I looked at through my loupes. So it was unsafe. I put down middle of the case, put down my instruments, cleaned my desk, walked out of work, and left work on disability. So like totally heartbreaking. And the next 2 months became just a fight with my insurance company. We have good insurance. And so without like relitigating all of the drama, I was denied a second round of Tepezza. Now, the current data is that 20% of folks need a second round of Tepezza, and that may go up to 40%. And there's nothing in the FDA approval that says that you should only have one course of that. And so I was denied this second round, despite this actually being a different insurer. They didn't pay for the first round. It was a totally different plan. So I was a cancer doctor for this company. I treated thousands of their patients over almost 20 years, and they wouldn't approve the drug, the only drug that could show efficacy in reversing double vision. And so as a patient and as a physician, this was appalling. This was the same company. I went on their board of director bios, and they're boasting about their profitability. And I'm struggling to get that drug approved. I wrote all these emails, tried to find some connections there, and I dealt with this arcane appeal process. And it was just ruthless in how opaque it was. I couldn't get names, information of the peer-to-peer retired general surgeon who was making medical decisions on my behalf, who had never met me. Couldn't even get the name of that person. Eventually I did, because I overheard them on their phone conversations in the background. I wrote it down and then found his name in multiple lawsuits. That went into my letter. And I couldn't move the appeal process on. So at my wit's end, worsening double vision, I was totally disoriented and increasingly depressive, looking at the end of my career. You know, I was 51, and I'm right at the prime of my career, you know, experience-wise and skill-wise, and it was just heartbreaking. So, surprisingly, at the advice of my medical team, I engaged a law firm in Boston that specialized in patient advocacy, which was the best thing I did. And a month later, shazam, the drug was approved, and I'm still undergoing treatment today. And 4 months after leaving work, I returned, and I'm hopefully working my way back to baseline. So, there's a lot to discuss with this disease. You know, it's an autoimmune disease. I think we have to recognize that. It's distinct from Graves, so it's its own autoimmune disease, just closely related to Graves, but it is standalone disease. And we really need more research into this. And it's increasing in prevalence like other autoimmune diseases. So we've talked about the acute phase. One important point, 8% of people can develop permanent vision loss from the optic neuropathy, so it is a vision-threatening disease. But even in the absence of that, it's really significant physically and psychologically, economically, holistically. I discussed the double vision, which was so disorienting and disabling, but like reading, driving, normal activities of everyday life, they all suffer. And so physically, what almost everyone describes is this eye pain, swelling, bulging, tearing, changes in visual acuity. So all of a sudden your prescription eyeglasses changes, double vision, which again is so disorienting. But it's this physical transformation that it leaves you with. And it imparts a terrible psychological effect on you. And I can't overstate how significant this is. And I've heard it echoed from every person I know who has TED. It's profound, the suffering from that aspect. You just don't feel like yourself. You don't look like yourself. You feel like your face, not just your eyes, is being taken over by this disease process. Something that we talk about is you become consumed by self-consciousness. In my case, I would just wear a mask and a face shield and goggles so that patients wouldn't have to see my face. You don't go out of the house unless you have to. You don't meet new people because they're going to ask you what's wrong. You don't see your old friends because they're going to wonder what happened to you. You never look in the mirror. You avoid photographs. You go through months when you refuse to have photographs taken of you. Isolationism becomes your predominant coping mechanism. And so you basically erase yourself and just try to get through it. And sometimes the depression is so severe you don't even want to get through it. So the emotional toll of this disease is really profound. So my hope from something like this today, hearing the science and hearing the patient perspective, is that it reflects this community of TED patients, which is a really varied group, but a shared suffering from this disease. And we need more research into TED, its causes, dietary triggers, effects. All the stuff that Colin had mentioned and more, the relationship to the endocrine system, hormones in general, diet, chronic inflammation. And so we need to fund research for more treatment options and even a cure, which means supporting funding to the National Eye Institute. I'm sure you're getting research from them. And not consolidating the Institutes of Health protecting that funding. As a dermatologist, watching certain inflammatory diseases with proper R&D over the last 25 years, such as psoriasis, it's gotten to the point now where many patients can live with practically zero disease, and that was unheard of 25 years ago. You practically cure some inflammatory diseases. So it's an inspiring success story that should drive us to support the science, and we can make a dramatic impact with funding. We also, as reflected from my story, need to increase, protect, and maintain access to the most effective treatments. Most patients can't hire a law firm to assist in obtaining treatment. So I was lucky. And this was appalling, not just because I was fighting for the only FDA-approved treatment, which at that point you shouldn't have to fight for it, but I was watching my disease just get worse and worse. My stress was exploding. I was having all these side effects. I've had 26 IV infusion treatments now over the past 2+ years. And so I was getting high-dose IV steroids every week, and nothing was working. And these were just unnecessary roadblocks that were placed in front of me. And then a final point, I think that we have to try to allow doctors and professionals, medical professionals, in their decisions toward most appropriate therapy. And by this I mean removing these required step therapy protocols that are required by many insurers. So you have to take X before you get Y before you get Z, and Z might be the preferred treatment. Because all that does is delay effective treatment when the medical decision making is clear, and it perpetuates suffering from disease and makes it harder to recover. And it lets insurance bureaucrats dictate care that doctors should be quarterbacking. So I feel very strongly about that too. So thank you for your time.
right, now we're going to have our final speaker come up, representing the Vision Health Advocacy Coalition. Olivia, do you want to come up and share some remarks and some updates that I think will resonate?
Yes. Hi, everyone. My name is Olivia Perry. I'm with the Vision Health Advocacy Coalition. Just a little bit about VHAC and some of the work that we do around these issues. So we are a coalition made up of patient, provider, research, and advocacy groups, including the Alliance for Eye and Vision Research, really working to promote patient-centered policies that make these services, devices, and life-changing treatments more accessible for people with vision conditions. And through our network of member and partner organizations, we really work to educate patients, healthcare providers, policymakers about access challenges, working to promote better vision care delivery, and advocating for access to prevention and appropriate treatment for all patients. We are extremely excited to be able to support the Alliance for Eye and Vision Research on today's briefing about thyroid eye disease. As we've mentioned, this week is Thyroid Eye Disease Awareness Week, so it's great timing for this briefing, but really helping to raise awareness about this disease and the needs of this patient population. For patients and people with TED, funding for research and innovation is just so incredibly important for providing patients with more treatment options, but that really is just the first step. We have, as we unfortunately know all too well in the advocacy community, having treatments approved does not mean access for patients. There are still a lot of barriers that end up getting in people's ways. As we heard, from Nathaniel, there are all these often insurance barriers that will get in the way of patients being able to access these incredibly important and life-changing treatments. So some of the ones that we often work around are things like prior authorization. So that's where TED patients and their providers are forced to get their insurance approval before they can access what is a clinician-prescribed treatment. And these delays are life-changing. These can last weeks or months, and that's time that a patient is progressing. That's time that a patient is in pain. That's time that a patient is missing out on life experiences. Things like step therapy, which Nathaniel had also mentioned, which forces patients to try and fail alternative medications that are preferred by an insurer before they can access the treatment that their clinician thinks is best for them. Again, this leads to delays. And then also finally things like non-medical switching, which is often one of the most infuriating ones, where insurers will push stable patients off of a treatment that is working for them because that is the treatment that is preferred by insurers. So again, all of these barriers that are being put in place for patients to access a treatment that has been approved and that may be working for them. And so these delays in treatment and denials really have these serious and lasting impacts on patients. And it's really important to have that timely and uninterrupted access to care in order for patients to get the best that they can out of their medication. There is some hope because policymakers do have a really important role to play here. We were really excited over the past few years to see introduction of legislation that does have an impact on these, so things like the Safe Step Act. So that's something that would require, these exceptions to step therapy protocols, making sure that health plans have a clear process to request exceptions, specifying timelines, really ensuring that patients are not forced through those unnecessary steps. The Help Copays Act was another one that we saw, and that would require health plans to count payments made by or on behalf of an enrollee to count towards a plan's cost-sharing requirements. This really makes sure that patients are not left at the end of the year with drastic and unplanned costs out of pocket. And then also the Improving Seniors Timely Access to Care Act, and that helps to standardize the prior authorization submission process for those in the Medicare Advantage plans. So it's really policies like these and others that are, being implemented at the state level that are really working towards ensuring that patients have access to these life-saving treatments. And so we are here all working together, to reduce these insurance and policy barriers because these are imperative not only for TED patients but for patients across the board, ensuring that they can have access to the treatments that they need. So we really, really look forward to continuing that effort with everyone here in the room to make sure that patients have access. And for those with thyroid eye disease, and really thank the Alliance for Eye and Vision Research for hosting this briefing today and for being such a wonderful partner in all the work that we do. So thank you so much.
right. Well, thank you very much, everybody. Again, I want to thank our sponsors, Amgen, the Association for Research in Vision and Ophthalmology, Research to Prevent Blindness, and the Vision Health Advocacy Coalition for helping make today's event possible. We do have a little bit of time for Q&A if anybody wants to stick around, but otherwise, we appreciate you all coming and really appreciate you learning a little bit more about thyroid eye disease, the impact that it has on patients, the need for continued research funding to look for new targets, new therapies, and try and help feed that pipeline so the industry can continue to develop and bring to market new treatments that can help treat patients. So thank you all for coming, and I hope you have a good rest of the afternoon.